It's a pleasure to be here. I want to thank the organizers, the Institute of Medicine. This is a great undertaking. Ruth and I have sort of engaged in a back and forth on these issues quite a number of times, and it's always a pleasure. I do not have any slides. In terms of people being interested in this stuff, Google OHRP. So I've been asked to basically give a little background on how the current system functions, what it does in terms of a number of the issues that Ruth raised, then go on to what has been proposed in terms of the advance notice of proposed rulemaking that I'm sure some of you are familiar with, and then I will probably comment a bit on what Ruth said. And hopefully, actually, I'm going to be pretty brief, and we'll have lots and lots of time for discussion after this. So anyhow, just Google OHRP. Right on OHRP's homepage, you will find direct links to the ANPRM and more information than you would want, including over 1,100 public comments on that. So lots of information in terms of the government's approach to this. I have to give you the usual disclaimer. These are only my personal views, in no way should be viewed as the views of the Department of Health and Human Services, the Office of the Assistant Secretary for Health, or any other subpart of it. Just sort of as a lead into this, what has been sort of my major take from a lot of my thinking in terms of Ruth's approach and what she and her colleagues have been proposing is that it isn't all different. In fact, it isn't that different at all in terms of, I think, even the government's goals in terms of the current system. I'm not here to say the current system is perfect. I think I'm sort of somewhat proud in terms of my relationship and being partly a motivator of the ANPRM, because basically it was the government acknowledging, and governments occasionally don't like to acknowledge this stuff, that maybe the current system isn't perfect, and that in fact there are a lot of problems with it, and we'd like to change it. And interestingly, again, my personal viewpoint is a lot of the changes in terms of the big picture and what we're trying to accomplish, I don't think my goals are all that different than Ruth's goals. Now, whether or not calling something a learning healthcare system and implementing certain changes is going to simplify things or improve the system in a certain way, I think that's the more complicated question. And part of the answer to this depends on looking at different aspects of the system in different ways. And I guess in terms of dividing the whole universe of research into two parts, the general way I end up approaching this is dividing the world of use of data, in particular secondary research involving data that we already have, clinical information and that sort of stuff. I'm certainly more in line in terms of what Ruth is trying to accomplish. And in fact, I think what a lot of Ruth is suggesting is not all that different than what the government is trying to accomplish. On the other side, in terms of what we might call interventional clinical trials, I think things get more complicated. And my concern, just I'm not hiding anything here, is that calling it a learning healthcare system, adopting all these rules, I don't think is going to remove all the questions that have to be answered. Lines have to be drawn in terms of what types of studies are we concerned about, where do we want informed consent or not want informed consent, and those difficult issues do not go away. And ultimately, it is about what kind of society we want to have, and under what conditions do we want certain types of activities to take place, with people having, to a large extent or a small extent or no extent at all, some ability to know what's going on and make their own choices about it. I think those remain hard questions, and I just am not yet convinced that moving to this learning healthcare system resolves those issues. So anyhow, big picture stuff. Okay, let me tell you a little bit about the current system. So I was asked to sort of comment on the risk-based nature of the current system. And again, the big takeaway here is the current system actually is very risk-based. Could it be better? Sure, and we'll see the government is trying to change that. But I mean, just to give you your kind of, bird's eye view of the current system. You have a number of categories of review, and basically the premise behind all of these categories, whether you recognize it or not, is that actually they're based on risks. The highest level of review in the current system is convened review. You have an IRB, it meets in a meeting, it discusses a study, it goes through a lot of aspects of the study. We're spending a lot of time reviewing those studies. Those are ideally the higher risk studies. You could debate how good a job the system does in terms of kind of putting things into that category versus other categories, but its goal is to be risk-based. Under that, you have expedited review. The premise of expedited review is, by and large, these studies are minimal risk studies. They don't need to go to a convened IRB. It could be expedited. It's easier to kind of get this stuff up and running and to conduct the study. You have exempt studies. Again, the premise is that exempt studies, if you fit into these exempt categories, these are low-risk studies. Don't need a lot of review. The goal is that the system is saying, let's figure out ways to get these studies out there, to allow researchers to conduct them quickly, et cetera, et cetera. So that's what the system, again, is trying to do. Does it do it perfectly? Of course not. But that's the goal. Just to give you some other aspects of it, even apart from those categories, there is a huge chunk of stuff out there that doesn't come under the rules at all. It does not meet the definition of being research involving human subjects. Both research and human subjects are defined terms. In particular, you could often do stuff that probably the average person out there would think that this, in fact, might be research involving human subjects, and it's not. The biggest aspect of this would be if you're doing research using de-identified data. So, and again, to indicate sort of how far the current system goes and in terms of allowing this, you could keep a one-way link in place, okay? So you're a researcher, you're mining massive amounts of data. You could be dumping almost every piece of data in existence on people in an ICU unit, but you're not getting their names, and so you don't actually know who they are. In fact, companies do this, and often, right, there are sales involved in terms of the amount of money that could be made from this sort of thing. As long as the researcher cannot reasonably identify the subjects, you do not have human subjects under the rules. You would not be under the common rule. When this rule was actually announced by OHRP, and this was quite a while ago, there were a lot of people out there, including my understanding is Ellen Wright Clayton and others who were actually saying this was going too far in terms of allowing researchers to do stuff. And it's interesting to see how far things have shifted the other way. But basically, the bottom line in terms of all of this is you could actually do a ton of stuff in terms of secondary use of data if you understand how the current rules work and you use the flexibility built into those rules. They really do allow you to do a lot of stuff. Again, do they allow enough? That's a debatable thing. But I know my office regularly works with people. Vanderbilt's BioView system, to give you some example, if people are familiar with that, a system that basically you're taking a mirror image of a massive database, basically everything that's in Vanderbilt's clinical, data system, and you just mirror it so that the researchers can figure out who the people are there, hash functions in place, et cetera, et cetera. OHRP staffers worked with the people at Vanderbilt to basically say, hey, you could do this. This is fine. It's not under the rules. NIH has its Beatrice system. Again, I mean, there are lots of entities out there that are doing this sort of thing. So there is a lot you could do on this side of it. Okay, so let me leave it at that in terms of what the current system does. So I mentioned there was an ANPRM, an Advanced Notice of Proposed Rulemaking, came out in July 2011. If you're interested in this field and you haven't actually looked at it, I do encourage you to look at it. It's not all that long. And again, there are wonderful comments that, depending on what particular subpart of this area you're interested in, by the top scholars out there and by most of the organizations that are involved in research and different aspects of it, over 1,100 comments out there. Okay, so the premise of the ANPRM, and there are two major goals, and one of them was certainly a recognition that although the system is currently risk-based, maybe it isn't as risk-based as it should be. And in particular, what it could do a better job at is on the low risk end of things, that maybe there are things that the system is currently requiring too much effort in terms of reviewing them, precisely because they're so low risk. We're spending too much time delaying this type of research, just frittering away money and that sort of thing, because we don't get anything in terms of increased protections to subjects. And so the Nprm went out there and suggested ways we could sort of tweak things, or more than tweak things, so that we would spend less time, have fewer administrative burdens and barriers to in particular, this type of low-risk research. And one of the major, when we're talking about low-risk research, we were particularly talking a lot about research that doesn't involve, physical risks to people. We're talking about perhaps, privacy and confidentiality breaches, that there should be relatively easy ways to keep those risks low, and perhaps even more so than the current system, allow that research to take place without a lot in terms of administrative barriers and much in terms of administrative review. So that's sort of one of the major themes of the ANPRM. This document is very much being worked on, actively being worked on, and hopefully there'll be a time when it goes out there for public comment and next permutation, and people could see whether or not it's sort of accomplishing that. But that is clearly one of the major goals and what it was trying to accomplish. So we're sort of in the same ballpark in terms of a lot of what the learning healthcare system is trying to do, is say, we have all this wonderful data out there, let's use it. So again, the government is very, in terms of this proposal, very much in favor of moving forward with big data and easing the burdens in terms of doing that sort of research. I was asked to comment on QIQA. I will note, and this is on page 44521 of the Federal Register notice about the ANPRM. It actually has a question about QIQA. Let me just briefly read it. The common rule has been criticized for inappropriately being applied to and inhibiting research in certain activities, including quality improvement, public health activities, program evaluation studies. Regarding quality improvement, for example, these activities are in many instances conducted by healthcare and other organizations under clear authority to change internal operating procedures to increase safety or otherwise improve performance, often without the consent of staff or clients, followed by monitoring or evaluation of the effects. A lot of that actually doesn't sound all that different than thinking about learning healthcare systems. It is far from clear that the common rule was intended to apply to such activities, nor that having it apply produces any meaningful benefits to the public. Indeed, its application to such activities requiring IRB review and compliance might have a chilling effect on the ability to learn from and conduct important types of innovation. And we see comment on how we should change the rule in terms of perhaps remedying this problem. So right there, smack dab in the middle of the agenda of this ANPRM. Okay, I'll leave it at that in terms of saying stuff about the ANPRM. So let me just finish up with, I've said a lot about the data side of it, and let me comment on sort of Ruth's points, because this is, I think, a very important part of the proposal. If we're talking about interventional clinical trials, and let me point out, even on this, I agree a lot with what Ruth and her colleagues have said. I certainly recognize there are comparative effectiveness studies that are probably not particularly risky. We have waiver rules under the current system that, in fact, you don't need to get consent in certain types of clinical trials if you meet the waiver criteria. I think the tricky part is ultimately concluding what are those trials. And I must admit to being, I guess, a little puzzled by some of the debate. When I initially responded in print in the Hastings Center issue where the papers came out, I did note, I think the difficult thing is figuring out which trials, in fact, we think you don't need consent, or perhaps you need modified consent, and which you do. And it's not clear to me we know where to draw those lines, nor that our society has sort of figured out what line drawing it is comfortable with. But again, there are some of these trials you don't need that sort of consent. I do find it interesting, Ruth, in other contexts, you did great work, I guess, with the IOM on, was it the TIDE trial, the Avandia stuff, where you were saying we had problems with informed consent. And again, a sort of trial, we could debate whether or not Avandia at one point or another was or was not no longer the standard of care. But the bottom line is, you have refined, my understanding, the examples in which you say, well, we don't need consent in these scenarios. Your most recent New England Journal article, which fits with the example you gave here, you're now putting in all these qualifications, comparative effectiveness trial, right, in which there are no delineated clinical characteristics that would favor one drug over another for many patients. What? Okay. Well, I'd love to, again, I mean, you were up there with others in terms of critiquing actions taken with regard to the support trial, and this is not the time and place to raise that, but on the other hand, what the lines are in terms of what trials you do not think informed consent has to be undertaken. It's one thing to say no good criteria for doctors picking one thing or another, and then a very prominent trial that got a lot of attention where there were lots of criteria that doctors were in fact using, and there was a lot of information that people knew, and many people went out of their way to say better consent. There was no need for better consent here. So again, this is an important point in terms of our current society and what people expect when they go to a doctor, and the flexibility a doctor has in terms of picking and choosing treatments. What I find sort of interesting, and I'll close on this theme, is how much of the push in terms of this broader discussion of learning healthcare systems keeps getting back to this notion of, on so many things in terms of clinical care, doctors are clueless. We actually have no criteria for, other than sort of, throwing darts at something, for picking one treatment over another, even if we don't have the gold standard clinical trial. And what's particularly ironic is that we now live in a world in which, in terms of decision analysis and decision making, we are doing better stuff and knowing so much more in terms of data than 10 years ago, 20 years ago, whatever it is. And yet the newest party theme seems to be pick any sort of medical topic you kind of want that we might want to do comparative effectiveness with. It's like if your doctor actually was picking among several standard of care options out there, your doctor is clueless. He or she has sort of no reasons to prefer one treatment to the other. And the key issue is to figure out when that is or is not true. And I'm not sure you're going to discover that everybody will agree so quickly that in so many of these actual scenarios, we actually don't have reasons, even not having that much data, for preferring one thing or another, or particularly for a patient preferring one thing or another. So why don't I leave it at that? I mean, I think that is the dilemma. And I'm not sure just calling it a learning healthcare system resolves the need to draw these lines. Thanks.